Good evening, friends. Today I'm back with the important topic which each and every obstetrician and a postgraduate must know. That is induction of labor. What are the current concepts? So I have taken yesterday class on initiation of normal labor. When normal labor does not set in, we may have to induce labor. And today's class is on that. Let me start with the case scenario. This actually is from the panel discussion that I had conducted once on induction of labor. I posed a case and then I asked the questions to the panelists. Today I'm alone here. Let me recollect some of the answers given by the panelists and try to give an idea how induction of labor is not understood properly and why it is important and what are the things that we must know. 25-year-old primary gravida booked elsewhere, not in your hospital. No antenatal complications according to the history. Why I'm saying so, you will soon realize. All investigations during pregnancy were normal. Again, I would like to put an inverted comma here. Pregnancy progressed 2 days only beyond EDD. I'm using the word only again to bias you. Her obstetrician had advised cesarean section. Now, this is the case that I posed. And the question that I will be asking comes up in the next slide. She comes to you for second opinion and further management. This is the usual scenario nowadays, that they consult one physician or an obstetrician and they're not totally convinced by the advice given by that particular obstetrician. They would definitely consult somebody else, either clandestinely or sometimes openly. So when the patient comes to you for second opinion with this much of history, what are you going to do? So to summarize the history on the top headline, that is unbooked case for your center, primary gravida, no complications, and 2 days beyond EDD. Advice given was cesarean section. First question that I asked the panel members, do you agree with her doctor's decision? The panel was divided in the opinion. Some said, yes, they agree, and some said they don't agree. So my question was, if yes, what are your reasons? Many of them said, nowadays we can't wait beyond 40 weeks. We don't know what is going to happen. Suddenly there can be IUD, and all those excuses were given. And of course, finally, they also said patient was requesting. That is the easiest thing that nowadays we are trying to give as an excuse for whatever decisions we take. Well, I didn't say anything much at that. If no, why not? There were, as I said, half of them didn't agree with straightaway cesarean section. In such a case where there were no complications and all investigations were apparently normal, and she had just crossed 2 days beyond the expected date of delivery. Now, what do you call that? Is it post-maturity? No, I'm going to explain that further. There are different names when a patient crosses EDD. It may be post-datism, past date, prolonged pregnancy, all those kind of things. Only when she completes 42 weeks will we call it post-maturity. So that has to be very clear to us. That is entirely different. So what is the difference between post-maturity and past/post-datism/prolonged pregnancy? This is very, very important for us to understand before we jump into any decision, either for cesarean section or for induction. What are the risks of post-maturity? I have already clarified What is the difference between post-maturity and post-datism? Post-datism is just going beyond the EDD, that is after 40 weeks, still she has 2 more weeks to go. But post-maturity is after 42 weeks. So what is the risk in allowing her to go post-maturity? If you go to the literature, when I was a PG, I read just 2 articles where they tried to go beyond 42 weeks. And in both the articles, they mentioned clearly their research work had to be stopped because of a lot of IUDs that happened. So nobody has dared to go beyond 42 weeks. People will say you can go beyond 40 weeks, then you have got next 2 weeks to take some decision. But nobody has ventured after those 2 articles that I'm talking about 1987, 89, that time. After that, I have not seen any article where they have gone beyond 42 weeks. So what are the risks of post-maturity? I am talking about pregnancy going beyond 42 weeks. Let me clarify this again and again. They tolerate labor very poorly. The babies which go beyond 42 weeks, they tolerate labor very poorly because, as you know, after 40 weeks, the placental reserve comes down drastically. Placenta doesn't die. In fact, I used to ask a question to undergraduates, who decides the length of pregnancy? Is it mother? Is it fetus? Or somebody else? Obviously, mother doesn't decide. And yesterday I told initiation of labor is decided by the fetus with the help of placenta. But again, fetus doesn't decide its duration of pregnancy as such, if you look at it. Then who actually has decided the length of pregnancy is 9 months in human beings, 10 months in elephants, or maybe less or more in other animals? It is the placenta. The life of placenta is limited. The placental life is almost 40 weeks in human beings. That doesn't mean that placenta is going to die on the dot or on the clock, 12 o'clock midnight of 40 weeks, but its reserve definitely comes down drastically. And after 42 weeks, it's almost non-functional. That's exactly why the babies tolerate the labor very poorly if you go beyond 42 weeks. Intrapartum fetal distress is again very, very high, the risk of intrapartum fetal distress. And they are born with very low UPGARs. So revival or saving them becomes that much more difficult. Meconium aspiration syndrome is again increased. And then, of course, more fetal trauma, because as the baby keeps on growing, there will be macrosomia. Even without diabetes, even without obesity of the mother, because baby keeps on growing. Baby has to grow, right? So if you allow the baby inside, it keeps on growing and it will become big and there will be trauma to the baby. So these are some of the risks of post-maturity. So today, at this juncture, I would like to conclude that nobody should go beyond 42 weeks. It's very, very risky. There's no question of induction or otherwise beyond 42 weeks. So let me come back to the same question, unbooked primary, no complications, EDD plus 2 days. I said, do you want any more history? Those who said, no, we want to do cesarean section, because the discussion went on in such a way, and I definitely agreed with those who said, no, we should not jump into cesarean section. So my question to the other half who said, yes, we would like to do cesarean section just because she has gone 2 days past date. I said, instead of simply blindly saying that, yes, I want to do cesarean section, or blindly saying I don't want to do cesarean section, I said, do you want any more history? Because sometimes what happens, the patient has been seen elsewhere. Not to put down our colleagues at the periphery or in the primary care or tertiary care centers. We have seen this. What is complete for me may not be complete for you. Or what is all investigations normal in my center may not be all investigations completed and normal in your center. I would have done 2-3 investigations and I said everything was normal. Maybe there were so many more investigations to be done. Maybe I would have asked history based upon my knowledge. Some more history, if you ask, the patient will reveal so many things. Even though she's primary gravida, maybe she would have undergone one myomectomy in the past, which she may not have revealed to you. She feels that that is not required. The doctor didn't ask me, so I didn't tell. So these are some of the things. Or the patient may not be aware what kind of surgery was done in her. There would be a scar on the abdomen, but patient doesn't know. So there will be some gaps when a patient was not booked under you. So that is why probably you have to re-ask some more history to take a proper decision. Okay, so I hope I'm clear in what I mean by do you want any more history? What further investigation report examination is needed? So you don't take things on face value. Sometimes, the person who refers the case to you would have written a very short history, maybe because of paucity of time, maybe because of ignorance or whatever it is. You can't just take that reference letter on the face value. You may want to do some more investigations. You may want to do some more examinations. For example, you may want to do an abdominal examination and a vaginal examination and take a decision. On abdominal examination, if you think that she's a case of CPD, then you are perfectly all right in doing a cesarean section. You see? So that is exactly why I'm saying, don't go by or don't fall into the trap of few information that you have. Just because she's unbooked, primary gravida, no complication, EDD, that doesn't mean anything much. Maybe the other person has not evaluated properly. So every single case, you have to evaluate, reevaluate, and you have to be convinced that I am taking a considered decision. I have considered the history, I have considered the examination, I'm convinced about the investigations that have been done. Otherwise, I may want to do more investigations. I want to reconfirm the status of the mother now, status of the baby now, because some of the things which can occur towards the very end of the pregnancy. There will be sometimes a very mild IUGR. Or maybe the fetal estimated weight is between 10th percentile and 50th percentile. We have seen a whole lot of things can occur even if the babies are in this range. FGR is different when the baby is less than 10th percentile, agreed. But 10 to 20 percentile babies are in trouble. If you induce labor in them, they may suddenly have fetal distress and you may have to do an emergency cesarean section. So obstetrics, yes, it is a beautiful, simple subject, provided you are prudent, you are street smart, and you also, try to understand the whole scenario, then only it is so beautiful. Right. What are the points to note in clinical examination? I just told you that you have to rule out CPD, number one, if it is cephalic presentation. You have to check whether she is in breach. For all you know, if she's in breach, then you don't even want to wait one more minute. Why just, go for a debate? There is no debate at all. Right? She's a primary gravida and at term, and not only term, she's 2 days EDD. What more you expect? If she's transverse lie, again, I wouldn't wait at all. I would straight away go for a section because it's not the time for, external cephalic version and things like that. Right? So that is the meaning of clinical examination. So you have to re-evaluate the patient. Then, will you order ultrasound now and for what? See, just because they said there is no complication, there are no problems at all investigations are normal, have you asked whether they have done an ultrasound? When was the last ultrasound done? For all you know, the last ultrasound must have been the anomaly scan. Thereafter, they may not have done an ultrasound. You want to do an ultrasound now. You want to see how is the Leica. You want to do a biophysical profile. Leica is the most important single parameter after 40 weeks. Every day you may want to do a Leica. And that's the one which is going to come drastically down. And that's the one which will determine whether you want to deliver early, whether you want to deliver abdominally, vaginally, can you afford to induce labor, all these things. Clinical examination also includes the per-vaginal examination, wherein you want to assess the cervix, status of the cervix. For all you know, if the cervix is long, uneffaced, or closed, you may think that it will take a long time. You have to ripen the cervix. So it is nothing but basics. You stick to basics. The clinical examination, both abdominal and vaginal, rule out presentations, rule out pelvic disproportion, and do an ultrasound, maternal health, fetal health. So if you stick to the basic points, you will not err at all. Do you want any other test? Maybe they have never done a sugar test in her. Maybe they have never done any anemia testing was done probably in the first trimester only once. She may be anemic now. So you have to, especially in a case of unbooked. So what is unbooked? Let me clarify that. Unbooked is a patient who has never come to you, or she has come to you, but less than 3 times. Now, 3 times is the minimum, but that 3 times should be in such a way that the last visit should be within 1 month of the delivery. Suppose she came out 2nd month, 3rd month, and 4th month. You can't call her booked case, because this is another basic, simple, general formula. Most of the pregnancy-related problems, they show up after 20 weeks and they keep worsening after that. So if a patient has never come after 20 weeks to you, how can you call her a booked case? So booked case is one, minimum 3 visits, fine, but the last visit should be within a month of the delivery, maybe around 36 weeks or beyond that. Only then can you call her a booked case, so that you know all the problems that are possible, especially in the late 3rd trimester, and you can take a proper decision in consultation with the patient. So that is the meaning of all this. So what is your plan of action now? After taking the history again, after doing the examination again, after asking for some more investigations, after doing ultrasound, is your plan of action same as the outside doctor or outside obstetrician suggested, that is cesarean section, or has it changed? Either way, you have to explain to the patient properly, because she has come to you for a second opinion. You can't simply say, yes, I agree with the other doctor and I would do a cesarean section. That is not expected by the patient. Patient wants you to explain to her, if you agree with the outside obstetrician, why do you agree? Is cesarean section really required? Don't think that if I don't accept, she will go back to somebody else, or if I accept, she may be unhappy. So either way is not correct. So you have to be clear in your decision, and you have to discuss the decision with the patient. All these things are important nowadays. Patients, after all, expect respect from you. Don't thirst your decision. Anybody, not only patient, people expect respect from you. And what do you mean by respecting others? Respecting others is that explaining your position, why you are taking a particular position, why you are doing that. See, order can be given only by an authority, but then nobody likes the authority these days. You have to explain. It has to be a consensus. It has to be a convinced manner. So then only patients will accept it. How will you counsel her at this stage? Either way, if you have planned to do a cesarean section, or if you plan to allow her for some more days, you have to explain to her with reason. If you have decided to go for some more days, you should tell her that, look here, you have no complications and there is no CPD, baby is fine, Liker is good, I can safely wait for some more days. And while waiting, I am going to monitor you very closely. You may have to come to me regularly, maybe sometimes every day if she is close by, or maybe at least once in 2 days. I'm going to assess the Liker, I'm going to assess the biophysical profile, and I will take action. And all those things you have to tell her. If she does not go into labor, when do you plan to induce? So that is also to be very clear. I'm going to explain that how long you can wait after 40 weeks. So anyway, that has to be explained to you, explained to the patient. How will you monitor until then and the frequency? That's what I just now told you. I'm not blindly asking her to wait. It's not that you say, okay, you have just passed 2 days, go for a party or go somewhere on a picnic and come back after 3 days. Probably she would deliver somewhere there in the picnic. So it cannot be just left like that. to fend herself. You have to monitor her very regularly. It may be, as I said, once in 2 days or every day, sometimes twice a day, if the liquor is going down. So all these things have to be explained properly, and the patients will accept that. What factors will make you change your mind or to review or intervene? So you must explain to her, as I'm monitoring, suppose suddenly these things happen, I may change my plan, I may stop waiting, I may go for an induction, or I may consider cesarean section, because towards the end of pregnancy itself, or especially after 40 weeks, things can change dramatically. So that's why you have to explain all this thing to the patient and win her confidence. So having given this as a prelude to my talk, now I will go on to the talk or topic of the day, that is induction of labor, the newer concepts. Now, what is induction of labor? There is nothing new. That's why I'm quoting the 2009 Obstetrics and Gynecology Journal. It is an intervention, obviously, intended to artificially initiate uterine contractions. Of course, labor means contractions, uterine contractions, resulting in the progressive effacement and dilatation of cervix. You ask any undergraduate students, they say, what do you mean by true labor pain? True labor pain is one which is associated with uterine contractions, cervical effacement, and dilatation. So you take that as the major chunk of your answer and just add artificially initiating that is induction of labor. Now, then there is another terminology called cervical ripening. Now, what is this? I'm quoting again the same journal, that it is a prelude to the onset of labor. Yesterday, we saw the phases of parturition. In that phase 2 is cervical ripening phase. It's a prelude for the actual phase 3, where the labor changes occur, or it's a labor, 4 stages of labor. So whereby the cervix becomes soft and compliant. It is able to stretch itself, either occurring naturally, see here comes that naturally, or as a result of physical or pharmacological interventions. I'm going to explain this, what is physical and what is pharmacological as far as cervical ripening is concerned. So is induction same as cervical ripening, or is cervical ripening enough to induce labor? I have clarified, I hope. So cervical ripening is a prelude to actual labor. And here, as you can see, we are only targeting the cervix to become soft and compliant. Whereas in induction of labor, we are trying to induce contractions in the uterus. Now, contractions will definitely help the cervix to efface and dilate also, because of the type of uterine musculature that we have. The longitudinal fibers are coming like this, and they are like bucket handle on the cervix and the circular muscles of the cervix. So as the uterus contracts, the cervix is opened up like that. So I always teach that cervical dilatation has got 2 drivers. Number 1 is the uterine contraction itself, and number 2 is the 360-degree pressure that the head is going to give on the cervix, mechanical pressure. So because of both, the cervix, dilates and effaces itself. So cervical ripening is a prelude to induction of labor. Sometimes the drugs that we use to achieve cervical ripening may induce labor also. There is nothing to get confused. There is nothing to get worried. It is a continuum. So because nowadays the pharmacological agents that we use for cervical ripening and the uterine contractions or inducing labor are almost same, that is prostaglandins. So when you are trying to do the cervical ripening itself, that can push her into labor, because when the cervix opens up, effaces, there may be separation of the membranes and natural production of the prostaglandins from the decidua and the endometrium. So that's why the uterus gets into contractions. Why induce labor? Of course, by now with my discussion so far, you may have guessed it, but let me elaborate on that. We induce labor for the anticipated benefits to the mother and or fetus, or that means both. Yes, if we wait, we may lose the fetus and then we may lose the mother sometimes because she can get into all sorts of problems. So that's why it is better to be prudent. So we have some benefits by delivering her in time or early time. So that's the meaning of anticipated benefits to the mother. Suppose she is having severe preeclampsia. You may want to induce labor and deliver her. It's beneficial to the mother. It is also beneficial to the fetus at the same time if the preeclampsia was so bad as to create a severe FGR and if the lichens have been less, or the baby would have a sudden IUD inside. So in which case it is beneficial to both. Preeclampsia is a typical example I took because you can see the benefit to the mother and benefit to the fetus as well. But of course, in preeclampsia, we always talk about primary benefit to the mother irrespective of the gestational age. But we always have a hidden agenda, that is the fetus. We want both. Estimated risks to the mother and or fetus. This is what I have already explained to you. If you wait indefinitely, you may lose the fetus. And if you induce labor at a wrong time, after waiting for a long time, then the baby would have grown so big, there will be shoulder dystocia that would put mother into risk as well. Induction is indicated when the benefits to either the mother or the fetus or both outweigh the risks of continuing the pregnancy. So you are very clear that by delivering her now, I am going to be benefited. I means the baby and the mother is going to be benefited and the whole family and the obstetrician is also going to be benefited. But by waiting, I may lose either of them or both of them and the whole game. So if you are convinced, go ahead and induce. So I'll go for what are the indications now. First, I'll talk about the fetal indications to induce labor because that's the one basically we want this fetus because it's very easy to save the fetus by handing over them to the neonatologist because it's not that we are incompetent of saving the fetus. It is that much more difficult to save the fetus when it is inside the uterus. It is an indirect treatment. Whereas when we deliver the fetus and hand over the fetus to the neonatologist, they can directly intervene. They can directly treat the baby. That is the meaning of it. So past dates by far is one of the most important indications. And as you can see here, it is not at 280 days. It is 280 days plus 7 days, 287 days. That is 41 weeks, 0 by 7 days. So you have waited whole term, that is 41 weeks. So then in the 42nd week, beginning of the 42nd week, you want to induce and deliver her because at any cost, you do not want to go beyond 42 weeks. The reason for inducing at past dates, that is after 287 days, the risk of meconium staining and asphyxia increases. The next one is GDM. Well, many of them say that if it is a well-controlled diabetes, you can wait for long and other things, but it is prudent to deliver them once they cross at least 39 weeks, because if you try to deliver before that, there can be double whammy in the sense the weeks between 37 and 39, 2 weeks, the chance of RDS is more. That is one thing. In GDM itself, RDS is more. That is another thing. So that's what I said, double whammy. So it's always prudent to wait for 39 weeks because after that, the incidence of RDS is almost zero. There is increased risk of macrosomia as well if you wait a longer time than that, and there can be birth trauma. FGR, as I said, FGR due to any reason, the baby is suffocating inside. It is always better to bring this baby out and we say catch up growth or treating them by supplying whatever it needs is easier, because whatever you give to the mother, whether you give IV fluids, people have given IV fluids, people have given oxygen, so now it is totally contraindicated. No, no. People have given glucose, people have given proteins, albumin, sildenafil, aspirin, whatever you do, it doesn't reach the baby. So it is always prudent to induce labor and deliver the baby. So some of the indications for immediate induction and delivery are absent or reversal of diastolic flow in umbilical artery, reduced cerebroplacental ratio, reversal of wave in ductus venosus. If it is very severe IUGR, where it is less than 5th percentile or even 3rd percentile, then it is sometimes better to do cesarean itself rather than induction of labor. Severe oligohydramnios, meaning AFI less than 5 and STP less than maybe 2. So in that case, you have to deliver her. And if AFI is less than 2 or 3, or if it is low like her, sometimes it is prudent to do a cesarean section straight away, because there is increased risk of intrapartum hypoxia. Previous unexplained IUD. It is said that if you know the cause of IUD in the past, and this time, if you find that particular problem, you have to deliver at around that time. But if it is an unexplained IUD, it is said that better to deliver this fetus 1 week before the time of IUD in the previous pregnancy. And if she is not in labor, it is always better to induce labor. Don't do cesarean section all the time. If there is no indication for cesarean section, there is no need to do cesarean section, but there is need to deliver her 1 week before the previous IUD, because the risk of IUD increases this time. And since she is not in labor, it's an indication to induce labor. RHIS immunization, whether you have done intrauterine transfusion repeatedly or even once, as you try to prolong the pregnancy, the risk inside increases. Whereas if the baby is delivered, then again, as I said, neonatologists can do exchange transfusion, and the antibodies that are actually trying to harm the baby is going to be lessened. So there's increased risk of hydrops and IUD if you keep it inside. The next one is unstable lie. I have put a question mark because unstable lie, should you induce at all, is a controversy, because if you induce labor and suddenly if the membrane rupture and should there be cord presentation, it can go for prolapse. But then there is something called stabilizing induction for unstable lie. So that's why I put a controversial question there. But anyway, if it is unstable lie, which simply means even after 36, 37 weeks, the lie is changing. Usually, lie is changing means it is the baby's head is not able to go inside. Before induction, in these cases, you have to rule out CPD properly. And again, ruling out CPD when the head is not aligned to the pelvis is also difficult. Maybe you have to just do a pelvic assessment. If you think that it is a contracted pelvis where all the diameters are 1 centimeter less than the normal, probably it is prudent to go for cesarean section. But you can just give a try with the induction in these cases, because there is a risk of PROM and cord prolapse increase. So you have to be very careful. Keep that in mind. Now I come to the maternal indications. Intrauterine death by far is one of the most common indications for the maternal reasons, because here fetus is dead anyway. You can't say fetal indication. Many a times we come across the patient and patient party asking to get rid of this dead fetus within 48 hours of its death. We have to have a clear idea. In my other talks, I have explained this properly. In the natural course, also, the uterus will get into labor, and it is always better to wait for that 2 to 3 weeks, but not blindly. You have to monitor her TCDC, that is total count and differential count. You also have to monitor the coagulation profile. And when it is time, when the baby shrinks, amniotic fluid shrinks, and then the membranes also shrink, naturally prostaglandins will increase inside the uterus. And that time, if you induce, the chances of successful induction are very high. But only thing is, counseling the patient these 2 weeks is the big challenge, but you should be convinced first that it is prudent to wait rather than to jump into. I have seen many people succumb to the request of the patient party. They induce and they fail and they go for a cesarean section. I wouldn't say it is criminal to do cesarean section for an IUD, but you really feel bad to give a scar for to deliver a dead baby. It's another matter that if the baby is very big and you cannot achieve vaginal delivery, that's why you want to do section even for a dead baby is another matter. But doing cesarean section for a, let's say, 36 weeks dead fetus, I can't accept that. I can't say I don't agree, but I can't accept that. It's very difficult to accept. Fetal anomalies. Yes, you don't want to do a cesarean section for a particular fetal anomaly because you know that the prognosis may not be very good. So you would like to achieve vaginal delivery. These are the cases, good fit cases for induction of labor. So psychological upset can happen if there are anomalies. They don't want to continue with the pregnancy because they know that ultimate outcome is not going to be good. Polyhydramnios. Other day when I took the class on polyhydramnios, it is better not to wait indefinitely for the patient because it can itself go for a rupture and then there is a problem. It is better to have a controlled situation. That's where you induce labor. Maternal respiratory distress can occur if you just indefinitely wait. Uncontrolled chorea gravidarum. This is one of the very rare indications for induction of labor. Now I come to the combined indications. We separately dealt with fetal indication and then the maternal indication. Now combined indication, I have already given you a clue what could be the combined indication. It is preeclampsia. Here it is for the sake of mother as well as for the baby, we are going to induce labor. And as I have already put another rider that if I have to choose between the two, then it is the mother we will always choose because maternal deterioration can harm her. You may lose the baby sometimes because you have done induction very, very prematurely. Baby was having severe IGR, but losing mother is so distressful to the family. Of course, we should not lose the fetus also. That is why it comes under combined indication. We want the baby, we want the mother, we want both of them. Chronic hypertension is again a combined indication. It's almost same as preeclampsia. Chronic renal disease, also the same reason for mothers as well as babies sick. There can be fetal distress. PROM, because there's increased chance of chorioamnionitis. If you indefinitely wait, I have seen a case where it was very difficult situation. Patient went into sort of sepsis and she went to ICU. It was very difficult situation. Luckily, she survived. So that is one of the indications. Especially if the PROM occurs at term, there's no point in waiting. You have to maybe maximum we wait 4 to 8 hours, and then if she doesn't get into labor, it is better to induce and deliver her. Abruption placenta, there is increased risk of IUD if you simply wait. So it is always better to go for induction and deliver, and that's the active management. That's what we say in abruption, active management, A for A. There's no question of waiting. What are the contraindications? I don't think I'm able to complete this talk today. Probably I have to go for